Hello and welcome to the second part of our three-part CME webinar series on interpreting and reporting F-18 Flurpiridaz PET MPI studies. I'm Muaz Malah from Houston Methodist Hospital. This webinar series, funded by an unrestricted education grant from GE Healthcare, is based on two reader training sessions held earlier this year where cases were reviewed from my computer using two different software packages, and we come up to a consensus on how to interpret these studies. In this session, we will review three abnormal cases and discuss issues that need to be considered when reviewing and interpreting these images. The faculty for this session includes Dr. Panita Shirintiwati, who is the co-chair of this program, Dr. Tim Bateman from St. Luke Mid-America Heart Institute in Kansas City, Missouri, Dr. James Case from Cardiovascular Imaging Technologies, also in Kansas City, Missouri, Dr. Rob DeCamp from University of Ottawa Heart Institute, Dr. Marcelo DiCarli from Brigham and Women's Hospital and Harvard Medical School in Boston, Dr. Jamshid Madahi from UCLA Medical School in Los Angeles, and Dr. Piotr Slomka from Cedars-Sinai Medical Center, as well as Dr. Jennifer Renaud from Invia Medical Imaging Solutions, and Dr. Prem Soman from University of Pittsburgh School of Medicine. Here are the faculty disclosures and the learning objectives from our three sessions. For each case, the faculty will discuss uptake patterns, incidental findings, and normal variants seen with F-18 tracers and how they differ from existing PET tracers. In this session specifically, we will review these images using a standardized systematic approach and look how these PET MPI cases will help you serve your patients and the clinical information you need to convey to your physicians. At the end of this program, there is a link you can use to claim CME. You need to complete an evaluation before claiming credit. So let's get started, and we'll start with the first case.
All right, so what do you think? Maybe I'll give this to James and then Rob if you want to comment further. So rest in the lower part, stress on the upper part, and we see this defect. And if we were looking at it systematically, this is your fusion data.
Guessing it might be a physics question, James.
Yeah, it's kind of sounding like it, isn't it, Rob? This is one where we have a CT image which isn't that great. You can see the little chips along the mediastinal edge. The heart seems to be laying out into the lung field. There are really three things that make up what I would call a good transmission study for attenuation correction. The first one is we have a well-defined boundary between the heart and the lung. The second one, which really isn't that big of an issue with PET-CT unless you have metal artifacts, is you have pretty much water attenuation coefficients in the mediastinal region. And then finally, the heart is well placed inside of there, not overlapping into the lung, or not excessively moved towards the right side and overcorrecting. So in looking at this image, it kind of fails on two of the three tests. We have kind of this little sawtooth effect. And this can happen in studies where you have a low number of slices, like a 16 slice machine in each one of the passes captures a small amount of volume, and you end up with this sawtooth appearance along the mediastinal edge. And the second thing you can see, especially as you get more to the base on the lateral wall, some of that heart activity is hanging out in the lung. We do attenuation correction. The attenuation correction is there to try and recover counts that are lost to the soft tissue. But in this case, if we attenuation correct with the lung, which has about anywhere between a quarter and a third the density of soft tissue, we don't get as many of those counts back. And so we lose those counts, and it gives the appearance of a drop in activity. So all those things work together if we want to go back over to the slice images. to what we see here. We have kind of a strange looking appearance to the anterior wall in the lateral wall, and you really have to. One of the really bothersome things about these misregistration artifacts is they can look like real disease, like this. Sure, yeah, you could talk yourself into a diagonal or circumflex, or even in some cases they look like left main type of thing. So it's not the sort of defects you can sweep under the rug readily. So that's why we have to inspect it. The other thing that we saw in this one is because flurpiridaz is a higher resolution agent, this is a small amount of misregistration causing this defect. Not even the thickness of the heart is enough to bring down those counts. So that's my sense of it. Rob, what do you think looking at this particular study?
Yeah, thank you. Great observations, James. I would just also, I guess, point out on the images themselves, of course, it's unusual to have a resting defect that improves at stress. So, that's one hint that would make you think about an artifact. And yeah, second, the attenuation misalignment, of course, most commonly observed in the anterolateral wall, because if there is misalignment, it needs to be corrected on the scanner console. This is something that your technologists will need to learn to do. And, there's a learning curve there for sure. And so, sometimes it can depend on the diligence of the technologist. And the last point, relating to what you described on the characteristics of the CT itself, would say, if you're doing a slow CT on a scanner with not many slices, very important, I think, to give instruction for shallow breathing to the patients. My own preference is if you have, a 64 slice or something, a higher capability machine might be, to try and target something at normal end expiration or expiration if you have the ability to do timing, because then the lungs are relatively deflated compared to the PET images, which are acquired over many breathing cycles, and the heart is a little bit easier to fit into the CT silhouette.
All right, so
So
thanks, Rob and James. I think these
yeah,
are all very important points, and I think it is, while this is important for any hybrid imaging, any PET imaging, this is going to become an important issue for flurpiridaz given its resolution. So our techs need to give us good images.
yeah. So I suspect many of the viewers here are in practices as opposed to major hospital systems. And it's not unusual for interpreting practitioners to show up in the lab at 4 and 4:30, and the technologists have gone home. You can't interpret these types of studies. It'd be foolhardy, and you'll make mistakes. Do you have any words of sage advice to the technologists so that they don't pass this type of misregistration on to the reading physician?
Yeah. Is it okay if I go first, James?
Go for it. Yeah.
In our center, we actually use a color table that has kind of a stripe in it at about like 50 or 60% of the peak activity. And we kind of tell the techs that 50% contour should be within the CT soft tissue. And that can help, to provide a kind of visual guide, a little bit more quantitative visual guide. I know on some of the SPECT imaging stations, the vendors actually provide a contour around the PET activity, and that can be helpful if there's known activity, as you can see here as well. So if you blend and just look, maybe decrease the blending there, Moaz, you'll see that white contour is definitely outside in the lung, right? And so that can be kind of a helpful adjunct for the technology.
So this is a 66-year-old male with a BMI of 27, hypertension, diabetes, dyslipidemia, and the patient is coming in with chest pain. And anything that you would like to add, Dr. Slomka?
There is a lot of epicardial fat in this case, so you see the heart is where the heart should be, I think, but there is epicardial fat, you see, so I think it's okay.
I think one very important thing on this case to plug in for assessment of calcium, you can see this is the LAD this is the left main, the LAD and the left circumflex, and all of them are heavily calcified. So clearly heavily calcified vessels, and the right also. So patient has multiple calcified territories as we see here. And here's the splash images, and I'll let you comment on that. Or Marcelo, if you wanna look at this.
So starting from the vertical long axis views, you could see that there is a defect involving the apex. Unlike the previous cases that we saw, in this case, we see reversibility in the apex. So in a case like this, we wouldn't call the stress defect as apical thinning, because you can see clearly reversibility in this particular case. If you then move to the short axis images, you see that in the apical short axis, you could see that if you look, for example, at slice number 17, you see that there is a perfusion abnormality that involves all the apical segments. And how do I know that? Because my reference is more to the base of the heart. And if you see the base of the heart, the base of the anterior wall and the septum in the stress images, you would see that the intensity should be higher. And so what that tells me is that all apical segments are involved in the defect. And you can see that at rest, there is complete reversibility of all apical segments. When you move to the mid part of the heart, maybe slices 20 or 21, you can see that there is a second perfusion defect involving the inferior wall, which is also showing reversibility at rest. And that extends even far into the base, that involves the inferior and the inferoseptal walls. So in this particular case, I think there's evidence of stress-induced ischemia in the mid to distal LAD involving apex and apical LV segments. And then a second area of abnormality seems to involve the mid and basal portions of the inferior and inferoseptal walls. So I would say that this is consistent with ischemia in the mid to distal LAD and right coronary territory.
There were some questions previously on TID, and this might be a good time to make some comments on that.
Yeah, so I honestly don't know what the normal value of TID would be for Flurpiridaz. I think we need to know more. What I typically like to see for TID is I need to see it visually before I rely on a number. The number is more to corroborate what I see visually. In this case, there seemed to be a mild difference between the stress and the rest images, and that seemed to correlate with that 1.14 that you see here on the images. I'm not sure if this is truly an abnormal ratio for Flurpiridaz. I think maybe Jamshid, do you know?
I think that these numbers have to be verified formally, but from my experience looking at a lot of these studies, the numbers are like, where we use a 1.2 as the cutoff for being abnormal, very similar to what we had seen on SPECT and on PET rubidium. But I think that but it has to be clarified. I would say for the time being, a cutoff of 1.2 is a reasonable number for TID.
Okay. All right.
We actually use 1.13 for PET ammonia, and I kind of feel like there's some similarities with respect to Flurpiridaz and ammonia, but I mean, this is just anecdotal.
Not anything. The ratios depend on the doses that you're injecting. For example, if you do ammonia, rest, and stress with the same dose, you would expect that the ratio will be close to 1.
Yes.
1.05. If you're injecting a low dose for ammonia and a high dose for the stress ammonia, then the ratio will be slightly different. And I suspect what Panithia is saying, will be similar here with Flurpiridaz, where we're injecting low dose and then a high dose for stress. So, but more to be determined. I think more important than just to get hung up on the number is it needs to be obvious to you visually.
Yes.
If it isn't visually obvious, don't believe in the number. That would be my rule.
I agree 100% on that. I think if you don't see it, don't because there are so many things that can go wrong in measuring this. Depends on the outline of the ventricle and how far into the base your regions of interest go. So it has to be visually visible to believe it.
Yeah.
The number is often a technical issue, but this one does look like maybe there's a hint of it, Yeah.
And actually, I just want to say, and I think Moaz read my mind, put the contours on, because you can see then, because sometimes the algorithm, when you read this TID blindly, you don't really know what the program is doing. And in this case, you can see the base. And if anything, to my eye, maybe it's a little undercalling it on stress, like in terms of the contour on the base. So that would just mean that the TID would be actually a little bit larger, but slightly. That's just what I see here. But I think it's okay in this case.
In any event, when you see multiple perfusion defects, you will typically see a little bit of TID because the counts are reduced, the wall gets thinner, and then the cavity looks larger.
Right. Yeah, you don't see the wall.
Yeah.
Looking at the quality, looks well registered and appears to be okay. We check it. So from now on, we're gonna move like the quality had been checked unless there is a specific quality point that we want to make. So maybe I'll ask Marcelo, or if you wanna walk us through here what you see.
There are a few findings here. Number one is the LV cavity dilates, with stress. You can see TID ratio there and on the right calculated at 1.44, but regardless of the number, you can visually see it very clearly there. And then the images show, like in the last case, a very, very large and severe perfusion defect involving the LV apex, the anterior and the anteroseptal wall from base to apex, and there is complete reversibility, again, consistent with severe ischemia throughout the proximal LAD territory. One additional finding that one can make here is that, at least to my eye, there's a little bit of increase right ventricular tracer uptake, on the images, on the stress images compared to the rest. And that would be another sort of high-risk sign, right? We have a TID, we have a large perfusion defect, we have transient increase in RV tracer uptake. All of those are high-risk signs that add to it. So I think it's a pretty straightforward interpretation in this one. On the gated study, one can see that there is obviously less thickening in the ischemic area. It's always hard to judge when you don't have many counts, but I don't know that there's a wall motion abnormality. It's just hard to see because of no counts. And then the ejection fraction. So where's the number? So I see a number 68%, but this is for what study?
So the rest was 76%.
76% going down to 68%, which again, not very surprising based on the findings that we had when we looked at the perfusion images. So now we have a full house of high-risk findings. We have a very large perfusion defect. We have transient dilation of the left ventricle. We have transient uptake in the RV, and now we have a drop in ejection fraction. Clearly all consistent with severe and extensive ischemia.
Okay, and now we're gonna ask Dr. Soman, can you tell us about the flow? And we did apply the correction, so we did correct for residual, we correct for motion, so yeah. So here, the motion correction, sorry.
So all the QA metrics have been checked, and so you have the flow here. And if you look at the polar maps, you have the territorial flow, and I'm looking for the global flow. Where is that?
There.
Okay,
Here.
that's great. That's great. So I usually look at the resting flows to make sure that they are within the normal limits of whatever is considered normal for that program and in your lab. For us, it's somewhere between 0.6 to about 1.2. And you see here that the flow is normal, the global flow is normal, and the territorial flows are normal and sort of homogeneous across the different territories. If you see one area of the resting flow is much higher than everywhere else, you have to try and figure out why that is. Usually it's spillover from some adjacent activity. Now, if you look at the peak stress flow, the global peak stress flow is very reduced. So we use a cutoff of about 1.8, and again, it's important not to use absolute binary cutoffs. It's about 1.8. This is well within the abnormal range. And the flow reserve, which we use about 2.0 as the normal. So you have normal resting flows, very abnormal stress flows, and an abnormal flow reserve, which is consistent with obstructive disease in the LAD territory. Now, the advantage of flow, of course, is you can look at the other territories and see what's happening there. And here you see that you look at the territories, myocardial flow reserve, both in the circumflex territory and the right coronary artery distribution, the flow reserves are normal, which means that it's very unlikely that there is obstructive disease there. Now, if you look at the peak stress flow, they're slightly abnormal. Now, sometimes if you have a large LAD territory, sometimes a bit of the lateral wall and a bit of the inferior wall can be included in that LAD territory, and the computer will erroneously attribute that to the circumflex and RCA territories. So you have to be careful when you interpret it based on the computer's allocation of territory. So here I would just say that, yeah, I think the flow is relatively normal in the circumflex and RCA territories. And so this mostly looks like single vessel LAD disease.
Dr. DeCamp, anything you want to add here?
I have something to add, actually. I think that we are learning a lot about flow with each case that I see, especially abnormals. I am learning a lot about flow. And I think there may be some nuances. Prem, you kind of use, I think what we have used for N13 ammonia, rubidium, for absolute flow and flow reserve as sort of our threshold. But I wonder, as you show more cases, I think we may have to, it may not be the same. And we've seen with other, for example, O15 water as well, that we may have different thresholds, different cutoffs kind of for normals versus abnormals for O15 water, and also for stress flow. And so I think this is something that we're learning with each case, and maybe just have to kind of temper a little bit with what we're doing.
None of the tracers are actually changing the underlying flow. It's the models for those tracers that may or may not be that great when we're talking about this big a range that we're trying to cover the blood flow from. So my guess is there's a lot of work to be done. We've never had a tracer quite like this that can go to have such a linear uptake across such a wide range of blood flows, and it does give us a tool for really understanding blood flow at a level that we hadn't been able to see it before. So there's a lot we're going to learn in the coming years with this. But as to whether the tracers are different, they're not really changing the flow itself. That's the regadenoson or dipridamol, whatever it is you're using in there. But the results we get out of the software will be different because the models are different.
I think that I agree that the peak flow values for this tracer, or what should I say, as James said, the measured or the reported peak stress values, depending on extraction properties of the tracer, and the model, are not as well studied yet as the relative perfusion image interpretation that was used for approval for regulatory approval of the tracer. And certainly there will be more comparative studies being performed and coming out, for example, comparing Flurpiridaz with O15 water, as a gold standard. So we should follow this closely, I think, still in the emerging literature.
Although I have to say that we've been using it, and I think, let's put it this way, where it is low, and where you expect it to be high, it's expected that you find it high. It's just the cutoffs that are not very clear. So, and again, whenever you draw a cutoff, if you draw a cutoff at 2, 1.9 is not very different from 2.1. So I think you have to look at it. But again, in this case, for example, we have a large perfusion defect. And I see in the LED, my peak flow is 0.9, while in the CIRC and RCA, my hyperemic flow is 1.6. So I'm very confident that the RCA and circumflex look pretty good compared to what we see in the LED here. And it's pretty reassuring. And even if you look at the flow reserve ratio, so I think overall it's heading in the right direction. Whether you would like it to be 1.7, 1.8, that's probably gonna learn more with the day. But at least where it should be high, we're seeing it high. Where it should be low, we're seeing it low.
I was just going to make a quick comment that rubidium and ammonia are so very different in their extraction fraction and linearity, right? But we use the same flow cutoffs. So that's why, and maybe Flurpiridaz and ammonia is the same difference as rubidium and ammonia. And so I think I agree with Muaz that the patterns are more different and the relative differences are perhaps more different. And, using these absolute binary cutoffs is probably not a good thing anyways.
Thank you for your participation in this online reader training program. Please be sure to tune in to part 3, which will feature a discussion on exercise with F-18 Flurpiridaz and interpreting and reporting abnormal studies. Hope to see you there. Thank you.